Hey, good morning, everyone, and welcome to the UroPatient podcast. I'm your host, Vic Sinise. We come to you every Saturday at 10:30 a.m., and we're here for you, the patient. Come to you live on YouTube, Facebook, and X. And you can always find out more information about our show at our website at UroPatient.com, where you can find the best information and past episodes. We have all sorts of handouts too that are available. You can download those for free. Just go to our website and check those handouts out and download those yourself. So we got a great episode for you today. Dr. Amy Hall is going to be joining us. She's going to be talking about pessaries. What the heck are these things called pessaries? What are they used for? I thought it might be a nice time to spend a little time exploring that and learning more about pessaries. So Amy, take it away.
So the first questions that we have to figure out when we're trying to figure out if we even want to use a pessary or if a patient wants a pessary, we have to figure out who are the best candidates. And typically those best candidates are the ones that either don't want surgery, can't have surgery, or just want to delay surgery until it's a little bit more opportune for them. But in sort of the segue to those who can't have surgery, typically a lot of our pessary users, if they're just unable to have surgery, it's typically because of a lot of comorbid conditions that really do diminish their ability to have surgery. They're just not good candidates, increased age, too frail, too elderly to undergo surgery. For younger women, we certainly see that prolapse is an issue amongst all ages of women. And so women who are still wanting future childbearing potential, they may opt for a pessary for use until they do complete childbearing. Certainly patients who may have had prior pelvic surgery may not want to undergo surgery again. I have to have surgery again. Here I am with another prolapse, recurrent, and they may opt for a pessary. And sometimes we'll use pessaries as a test. Patients come in with prolapse, not necessarily overly bothered by it, but they want to see if it might help the symptoms that they have with their constipation. Maybe their constipation is due to their prolapse, maybe it isn't. And so you could use it as a test to see if it improves other symptoms that may or may not necessarily be resulting from a prolapse. And certainly patients who are candidates for pessary have to be open to it. If they are not open to it, it's not an option if they don't want to consider it. And certainly, thankfully, insurance doesn't require that patients attempt pessary management before they can be candidates or approved for surgery. And so, thankfully, if patients are not open to that pessary, obviously, if they are wanting correction, they do have surgical options. So there's lots of different considerations that we have to factor into pessary fitting. I typically bring patients in for a 1 hour, what I call pessary fitting procedure. It takes about an hour so that I can discuss the pessary with them, do the fitting, test it to see if it's going to work or not work, maybe try other pessaries at that visit. If I find a pessary that works for them, that's comfortable, and I've tested it and it stays in, then I also in that visit teach them how to take it out, put it back in. I do strongly encourage my patients to have self-management, and we will talk about that here in just a bit. But not all women can use a pessary. There are certainly some women who may want to opt for a pessary and just cannot use it for various reasons. We can't, for example, achieve a fit. Those patients with short vaginas, again, prior surgery might shorten a vagina, changes the anatomy. Women with much wider genital hiatus, that's the opening of the vagina, essentially from 12 o'clock to 6 o'clock. So a wide or wider genital hiatus might prohibit a pessary. We need to know the patient's pelvic organ prolapse stage. And so the bigger the prolapse, it might be more difficult to get a pessary fit, or we may have to consider only other certain pessaries that might be more conducive for larger prolapses. We have to look at the patient's epithelial compliance. So the vaginal epithelium needs to be healthy. And so certainly an elderly patient tends to be the predominant pessary user. They may be more likely to have a lot of vaginal atrophy. And so we may have to work with that vaginal epithelium first before we can consider that pessary fitting procedure. It's not uncommon to try 2 to 4 pessaries in a fitting. However, beyond that, it's potential likelihood that we're not going to achieve a fit. If I get to a 4th pessary in a fitting procedure, I typically call it and say, okay, you know what, we can come back another day and try some other types that I have. But it's quite uncomfortable to have in and out pessaries, multiple pessaries in a visit. And I really do want to be very mindful of creating a lot of discomfort and potential for vaginal bleeding. So if they're still up for it, I might try some more, or we might just call it and bring them back in another day. I typically, what research we have, we don't have a lot, but what little bit of research we have on successful fit, we see ranges between 63 and 86%. I've seen lower, I've seen higher. But sort of the majority that I've seen amongst research with successful fits is anywhere from around 60 to 85%. Certainly a fitting trial is a no-lose option for a willing patient. So it might work, it might not. And certainly a lot of women, you know what, I tried it and I love it, or I tried it and it helped me realize I do want to get surgical corrections. So it's really a no-lose option for women to help them make their decisions. So this is just a little bit of information on the genital hiatus and kind of giving you a little bit of a guide on what pessary might work better for a woman with that larger genital hiatus. So a larger genital hiatus may be anywhere from 4 centimeters or more. Most women, if you've got about a 3 to 3.5 centimeter, even a 4 centimeter genital hiatus, you might be able to go with a ring type of a pessary. This one here is a ring with support, a real good pessary. That's my first line pessary. It's my go-to pessary that I typically choose for women who have a smaller hiatus. Women who might have a larger genital hiatus, that 4.5, 5 or greater genital hiatus, I often do go with my Gellhorn pessary. And you have options with your Gellhorn. You can do a regular stem, which is this, or a shorter stem pessary. So for those patients with much shorter vaginas, you can also opt for what I call a short stem. I think it's what it's called, short stem Gellhorn pessary. Because that shorter vagina, as you can see, a little bit of a idea with these pictures here, even though this patient in this picture in this schematic has uterus, most women with those shorter vaginas have had prior surgery, and it's usually a hysterectomy or other pelvic reconstructive type of surgery. And so that's typically what shortens that vagina. And that short stem Gellhorn, again, tends to be a really good option. Again, this is a regular stem, but a good option for those shorter vaginas might be that. A lot of the shorter vaginas, I can't even get a ring with support to fit, because as you see in the bottom left, that type of pessary oftentimes sits in the vagina like this. Well, sometimes it sits more like this. And if they don't have the length, then there's no way this pessary is going to be able to sit in that vagina like that. And so that's why that short stem Gellhorn can be a good option. I do use cubed pessaries. They're not my go-to, but I have been using them a little bit more. The caveat with the cube pessary is I do certainly pick and choose who I'm going to fit with a cube, because I really do want them to be on board with self-management. That is my ultimate, I call it my ultimate suction producing pessary. And so I really do want them on board and able to demonstrate that they can remove and reinsert that pessary. So our fitting procedure, as I said, I typically have a 1-hour fitting procedure. I always do a speculum exam first, take a look at the epithelial integrity. I don't necessarily need a speculum to do a fitting procedure, but I look at the vagina skin. I call it the vagina skin to make sure I got some good vaginal epithelium that's going to lend itself to a little bit more of a successful fit. Again, I evaluate the genital hiatus. I look out also the perineal body being the part of I call it the fat pad that separates the vagina from the top part of the anus. So that thick skin and muscle that separates the vagina, the very bottom part of the vagina, with the anus, the anal meatus. So we need a good perineal body, need a good thick fat pad there. You need a relatively reasonable genital hiatus to consider what pessary you're going to start with. I look at length and width of the vagina, and I'll show you all a picture of that here in a minute, but it's essentially 2 fingers in the vagina. Get an idea of length, get an idea of width. And then I go to selecting my pessary from that point. I use a lot of lubricant. I use a lot of the Trimisan ointment that comes with our pessaries. I just tend to do better with that. KY, some patients burn with it, so I do pretty well with Trimisan, lots and lots of Trimisan. So again, as I mentioned, this is my picture to evaluate length and width. And so essentially, 2 fingers in the vagina, spread them, as far as I can. If it's this, then maybe I need a smaller pessary. If it's this, a bigger pessary. And essentially, I'm just guiding myself. Okay, I can do this. So that's probably a number 3 ring with support, which is what this is. This is just another really nice picture to give you an idea of how we're fitting patients. This is just a couple of pictures that I like to show people about how pessaries typically fit in the vagina. The one on, I think it's your left here, that's probably a ring with support. The idea is that it's fitted behind that pubic bone, but you'll kind of see it's facing that introitus, and if it's facing a little bit more toward the opening, again, that's okay if it's fitting and stays in for the most part for the patient. Gellhorn fits just like that, just in the vagina. That concavity creating a little bit of suction. So it's a little bit of a suction producer that can be a really good pessary for maybe a pretty good size uterine prolapse. And then that one on the right there, you can see the tip of the cervix. And so I'm assuming it's probably a ring without support, which we'll use a lot of times in our pregnant patients who have prolapse and need something to help elevate that uterus, at least until they get further along in their pregnancy, when the uterus comes up and out of that pelvic rim. We'll use those kinds of pessaries, rings without support, so that they can still have the cervix not be irritated potentially by that pessary, but long enough until they can get further down the second, third trimester and get that uterus up and out of the pelvis. So confirming proper fit. If we get a fit comfortable to the patient, we want to see if it's going to stay. And so we'll have the patient Valsalva, and we'll have them cough. We'll stand them up and have them do those things. And a lot of times I'll have the patient bend and squat and do the things that maybe she's wanting to do, maybe working in her yard, working in her garden. She's doing a lot of bending and squatting. So I said, hey, let's try that with this pessary in. Let's see if it's going to work for you. Do the things that you feel like you can't do, that you're not doing, that you're wanting to do, and let's see if this pessary will work for you and let you do those things. And so we'll have them do that. And if it works, stays in, it's comfortable, then we'll have them go sit on the toilet. We put a little hat in the toilet. We don't like to fish pessaries out of the toilet. We'll do it if we have to, but we don't like to. So we put hats in the toilet. And if it falls into the hat with them Valsalvaing, then maybe we try another size. We go next size up. If it falls out while they're urinating, if they urinate and it falls out, I'm certainly going to go next size up. I tell patients all the time, if you're pushing and pushing and pushing and pushing, and then finally that pessary falls out, may not be perfect, but it might work. I tell patients all the time, if I can keep a pessary in 90% of the time, it is not perfect, but it may be satisfactory. So if I can keep it in and it never, ever, ever falls out, except maybe when they're trying to have a bowel movement, maybe they just need to take it out, have the bowel movement, put it back in, or have a hat at home, and there's their safety net. We want to re-examine, once we've had them do all of that, we want to re-examine the pessary and make sure it didn't shift, didn't move, it's still comfortable. And again, resize if it slipped or if it fell out. If it's uncomfortable, even though it stayed in, maybe we need to size them down. If it didn't stay in and we size them up, we still want to confirm that they're comfortable, because again, we're not trying to trade one problem for another. I like to tell the patient, I want you to be unaware of the pessary. Or if you're aware of the pessary, it's something you can easily forget. I don't want them constantly reminded of their pessary because it's falling out all the time or because it's uncomfortable. Again, I'm not trying to trade one problem for another. So I don't want them hurting. And I want to know that their symptoms are relieved. Is that pessary holding that bulge up satisfactorily? And is it helping them do the things that they want to do? So I often help patients learn how to self-manage their pessary by doing a lot of gyrations in the office. I use models to help them understand and to kind of see a little bit more three-dimensionally how to remove and replace their pessary. And so I've got this little model here. And so I'll often show patients, if they've got a ring with support, I'm folding it in half along the big holes. That's the only way it really likes to fold. It doesn't like to fold this way. So I'm, really doing a lot of practice with them. And I'm inserting it. Whoops, sorry guys. Trying to make sure you can see until I can, get it in. And I'm basically showing them with use of models or just with my hand how to do that to get it in for them in the office. We want to talk about how to take care of their pessary. Good old soap and water. I tell them body wash, shampoo, bar soap, doesn't matter. Just wash the pessary with soap and water. Get all the soap out of the holes, and make sure they have good clean hands. They do not need to use gloves. They can use gloves if it helps them grip the pessary better. It's not necessary. They just want clean hands, clean pessary. And these are just some positions for removal and insertion. There's no wrong position. I talk with my patients a lot about what's comfortable for them. Some of my elderly patients will insert it on the toilet, remove it on the toilet. Some of them will do it laying on their bed. It just kind of depends on what they can or cannot do and looking at their functional disabilities or functional abilities. Again, self-management is best. At the very least, I like for them to take it out one time per week for an overnight rest. So a lot of my patients will take it out Sunday night, put the pessary back in Monday morning. Some patients will take it out every night. It's not mandatory, but some people feel better with that, and that's fine. Again, a little bit of research we've got did show that at least one time per week overnight removal and vaginal rest did help to maintain a good, healthy microbiome in the vagina, and there was reduced risk for infection, erosions, things of that nature. If the pessary tears, cracks, we do need to give them a new one. Precautions include foul, horrific smelling discharge, vaginal bleeding. I always make sure that before my patients leave the office that they know the 3 things to look out for. Pain, if it doesn't feel good, doesn't feel better, I need to know. Bleeding, that's not okay. And foul, horrific smelling discharge. I want to check that out. So any of those 3 things I need to check. Sometimes I need a little bit of help with self-management. Good old dental floss is always a help, kind of like a tampon string, helps them pull the pessary out. They just have to use unflavored. It can be waxed or unwaxed, it doesn't matter. If they're going to use a dental floss string, I like for them to take their pessary out every night, just because that string probably should get changed out every day. It can get kind of gross. So I would recommend a little bit closer self-management a few more times per week if they're going to use their dental floss, or at least use it until they can be more comfortable with removal and insertion without it. The picture down below is called the Pessary Assistant, developed by an OBGYN. It's a website, pessaryassistant.com. I've had several patients purchase it. I think it was like $20, definitely overpriced. But the U-shaped end is the end that they put the pessary in, let it sit in there, and then the device goes in the vagina and helps to get the pessary in. The hook on the end helps them to hook the pessary, like that crochet looking hook thing there, so they can pull it out.
Well, Amy, that was really great. I really appreciate all the information you had to share with everybody. Again, I hope that this is good information for those of you that may be considering a pessary, or maybe you have a pessary and had questions about it. As always, join us on UroPatient every week to learn more about your urology questions.